The next speaker is talking about melanoma diagnosis and treatment. It's Associate Professor Mark Smithers. Most of you will know him or heard of him. He's also on our board. Associate Professor Mark Smithers is one of the leading surgeons in diagnosis, treatment and management of melanoma in Queensland and indeed Australia. While serving as a medical director on Melanoma Patient Australia Board, Dr. Smithers is the senior surgeon at the melanoma clinic based at the Princess Alexandra Hospital. In his role as chairman of the Queensland Melanoma Project, Associate Professor Smithers oversees the successful operation of clinical-based trials for melanoma patients managed through the PA hospital. He is also actively involved in national and international collaborations of melanoma trials. Can I welcome to the stage Dr. Mark Smithers.
Thanks very much. It's a pleasure and a privilege to be here to talk to you today. So there's a fair bit I can talk about, and so I try not to ramble too much, and maybe in some areas I won't have gone into the depth that you might want because that's particularly where you're interested. But at least if I touch base with that, and I understand that through the day there will be opportunities for us to have even more discussion than just say questions, where you can try to tie people like me down a little bit tighter than maybe in a question time. So, and I'm happy to be tied down if that's the case. So I really do need a pointer. So, and I do have one, so we'll get going. So just a few little definitions here. Lesion, I'll keep falling into medical jargon, and I apologise for that. But I'll try not to too much. But a lesion is a spot on the skin. Nevus is the same as a mole. A dysplastic nevus is where the pathologist sees some changes. The other word is atypical, as Pip used, but we sometimes use the word dysplastic, and it means that the pathologist thinks it looks a little bit different to just a normal mole. Primary melanoma is the first one that occurs on the skin, so that's the malignant mole or lesion. And a secondary melanoma is when the cells from that primary have spread to a site away from the primary site. A lymph gland is the same as a lymph node, and they're collections of lymphocytes that live in different regions. We've got them all over our body, but in particular relevant to this discussion is the neck, the armpit or axilla, or in the groins. And prognosis is the chance of being cured or the chance of the cancer recurring. So bad prognosis means the risk of it coming back is high. Good prognosis means the risk of it coming back is low. So let's get on with it. Primary melanoma I'll talk about, management of lymph nodes, what investigations, follow-up, advanced disease. There's a lot to deal with. Neville Davis started the Queensland Melanoma Project in 1963, and Pip alluded to that. And he said that melanoma writes its message on the skin with its own ink and is there for all to see. Melanoma can be diagnosed at an early biological stage when relatively simple excisional surgery carries a remarkably good prognosis. What he said then was right then, and it's right now. So not much has changed. What we want as a clinician, when somebody comes with a mole, we want a history, what's happened to the mole, and as a clinician I should understand the implications of what you're telling me. I should have a knowledge about the appearances of different types of melanomas. I'll get to answer your question, Pat. We need a good light and we need magnification, and there are ways that we can do that. What we then look at is this A, B, C, D and E. It's a simple way for people to think about it and remember. So we're looking for asymmetry. Is this thing in front of us symmetrical or not? We look at the border. Does the border blend with the skin or is it cut off? We look at the colour or colours, plural. Not always black. Not always black. We look at the diameter. And the bigger it is, the more worrying it is. But you can still get them small. Nothing's 100%. And we look to see if there's a great change on the surface. So this is an example where we're looking at asymmetry here. The shape of one half doesn't match the other half, so if you try to fold it, it won't fold at all. We're looking at the border and it's very uneven. the colour, different shades. You can't quite see it in the light, but there are different shades. It's greater than 6 millimetres, so that increases the risk, and it was slightly elevated. So I walk in, somebody walks in and that's sitting on the skin. I look at that and I say, that's a melanoma. It's not always so easy, unfortunately. So, and I think I've just told you all of that. You've just made the diagnosis when you looked at these two things, didn't you? So now when you see that, that's a melanoma. So that's actually, looks like, for those who aren't from Queensland or from southeast Queensland, that's Peel Island, and that's Horseshoe Bay. That's an island in Moreton Bay out there. So I use these when I talk to students too, so they recognise that. And you can see that even though that's very regular, it's just abnormal with lots of different colours. It cuts off right at the edge, whereas this is very irregular. So that's a melanoma. And that's another melanoma. You see, there was a previous mole. 50% of melanomas will occur in pre-existing moles. That means 50% will just occur. It can be just brand new, but half will occur in a pre-existing mole. So you can have a benign mole that changes. So, and that's what happened here. And that looks like it's a little black thing you could just flick off, but it's not. And this is not pigmented, but that's a melanoma. But that's abnormal. So somebody comes in with a history and says, hey, this wasn't here a few months ago, and it seems to be changing. So me, as a doctor, my differential diagnosis is going to be, is it a BCC, skin cancer? Is it a squamous cell cancer, skin cancer? Or is it an amelanotic melanoma? All three things need to be removed. So you don't actually have to have the diagnosis of melanoma. You have to have the diagnosis of this is not normal, this shouldn't be there, it should be in the bucket. And this is another form of melanoma that occurs in more elderly people and is always related to sun exposure. So this was what's called a Hutchinson's melanotic freckle, and it's called lentigo maligna melanoma. That's the medical term. And that's a diffuse thing, usually seen on the face or on sun-exposed areas. And it's an irregular area of pigmentation. So a little bit tougher to make the diagnosis. But this person comes in, and this may have been there for years, and they say it's changing. There's the word, changing. And then here you can see this was treated as a fungal infection. So, and it wasn't getting any better. So the trigger here is you should biopsy it. This is a lot easier. You can tell that shouldn't be there, but that one's a lot harder, no pigment. So the non-pigmented ones get diagnosed later because it's more difficult. So when we examine a patient, we examine not just the mole you talk about, but the rest of the moles, because I want to compare that mole with what else you've got. If that mole looks exactly the same as everything else on your skin, it's probably okay. And that's just to stand off before I even start looking at it closely. I want to use your moles on your body as your own comparator. So immediately you're going to be able to get a feel for this if you're having to look at somebody's back and you're not even trained. That you look at the back and everything on that person's back looks exactly the same, they're probably okay. But look at that, there's one there just standing out like a shining light. That needs to be checked. It's not rocket science. So, and we use a dermatoscope. It's an instrument that will magnify what you're seeing, but also give us a great light to look at it. We can use oil, we can use other little tricks of the trade, but it's the magnification and good light that matters. So this is what I was talking about. This person comes to see me, and this person has 200 moles, so this person has a risk of melanoma. But when you look at this, they're all pretty similar. But I want to look at that one. It's a bit bigger. I want to look at that one. It's a bit irregular. I want to look at this one and this one and this one. So I'm not going to be there for the next 2 hours staring at every single mole. I know that all of those are okay, and there's some that I need to look at much more carefully. So when I look at it closely, see, I've taught you now, you know that's benign. But I've taught you now, you know that's not. So that's Africa. So moles shouldn't look like Africa. They shouldn't look like Peel Island. They shouldn't. So you can see immediately lots of different colours. It's got an irregular edge. It cuts off, and that was on that same patient, and that's on his shoulder. So you can see how different that looks compared to the rest of the moles that he had on his body. So it's tricky when you're looking at people with lots of moles, but there are little clues. 15 to 20%, Pat, will be non-pigmented. Pat's been in my office, not Pat professionally, but I don't have any of those things on my walls, because I don't want people to believe that every melanoma will look like all the ones that I've just shown you. Lots of other people put those up, and they're really important, because that means that's 80% of the melanomas we see, and we see them and we diagnose them early. And when we see those ones, we diagnose them early, we cure patients. But this is the tricky group, and this group get diagnosed late. Because this is that one there that was treated as a fungus. This is just a funny area, and this is an elderly patient who just said they've been scratching away at this. And you wouldn't believe that that was a melanoma, but it was. But when I give lectures to students, I say, but you look at the differential, and I would have diagnosed that as a BCC, a basal cell cancer. That's a skin cancer, and I would have said it needs to be removed. So all you really do is you have to diagnose that it's abnormal and it shouldn't be there, or it should at least be biopsied, and the same with this thing here. And then this is another one. That's on the ear of an elderly man. Well, it shouldn't be there. And as you see, it did have a biopsy, and that was a melanoma, and this thing was changing, and this person wouldn't allow it to be removed because of where it was, but this was increasing in size, and that's an amelanotic melanoma. So it's a new thing. The history was new, not there before, and it's changing, so it needs to be removed. And you'd be worried about that thing, but this is the melanoma. But the history was, it wasn't there 6 months ago, it's a recent, and it's changing. So it goes. So any changing lesion, not diagnosed, this is what I say when I teach, if you can't make a diagnosis that it's clearly benign, and there's a history of change, and you're not absolutely 100% happy, when you look at it with the magnification and a good light, it needs to either be removed, biopsied, or referred for those things to happen. So I teach that, and if you have that, that's what you insist upon. So the prognosis now. Prognosis is about outcome. What the prognostic important things in melanoma relate to the thickness under the microscope, and the pathologists give us that. Relates to whether it's ulcerated. It's a little bit worse. It means it was probably thick, but then it's had some ulcers, and it's probably biologically aggressive tumour. Whether the lymph nodes are involved or not, or whether it's spread to other sites. Level and stage are commonly confused. You're diagnosed with a level 4 melanoma, you get on the internet and you look up stage 4 and you think you've got a 5% of being alive at 5 years, because that's the figure. But if you've got a 0.7 millimetre level 4 melanoma, you have a 95% chance of being alive at 20 years. So level versus stage. Level is the anatomy of the skin. The skin has 5 levels, and level 4 is one of those levels. Stage is the extent of the disease, whether it's confined to the skin, whether it's gone to lymph nodes, or whether it's spread elsewhere. And it's stage 1 to 4. So that's the mixture between the two 4s. So this is level 1, 2, 3, 4 and 5, and these are the layers of the skin. This isn't a lecture about, you don't have to remember this, there won't be questions after, you won't get an exam, but that's just to point out this is where level 4 is. And it's just there are 5 levels of the skin. And the levels that really count are this level 1, and Pip used the term in situ. Level 1 is this most superficial layer. So I describe that to patients by saying that's our waterproofing layer of our skin. It's made up of cells. Then we have 2 layers that give strength. This is called the dermis. And then we have a layer of fat. Some of us a bit more than others. So level 1 is in that layer of cells. And if the melanoma is confined to that level, with excision, you're cured. because there are no blood vessels or lymphatics in that layer. The incidence figures that Pip gave excludes level 1. If you look at in Queensland, up to the age of 80, the lifetime risk of any melanoma, including level 1, is 1 in 6 for men and 1 in 10 for females. So we diagnose a lot of level 1 melanomas now. That's good. That means people are going and having early diagnosis. So, and they're cured. Level 4 is, as I explained, is a deeper level. The stage of melanoma, 4 stages. Stages 1 and 2 relate to the thickness that the pathologist gives when they look at it under the microscope. And stage 3 relates to whether the lymph nodes are involved, and stage 4 is if it's spread to organs. And the thickness, and what we look for when a pathologist gives us a report, is we look for the thickness. We want to know whether there's ulceration because it's a worse prognostic sign. We want to know whether the cells are dividing, that's mitosis. There's this word regression, where the tumour seems to be dying or disappearing. There's no evidence that regression is a bad prognostic sign. We think it may be an immunological reaction, we're not really sure. And then we want to know whether it's invaded into other things like nerves or lymph channels. So what we want, these are those levels, the epidermis, which is this top layer, and then the dermis and the fat, but they give us the thickness. And this chap, Breslow, was the first person who described that in the early 70s. That's still the most important prognostic sign, above everything. And then it's broken up. So T is the staging, is T is the thickness, N is whether the nodes are involved, and M is whether it's spread. So it broke the thickness, the primary, the first melanoma is broken into 4 T stages. Stages 1 and 2. So it's all very complicated, but it just gives us a feel for who's at a bit of a higher risk compared to others. So that it's broken up into stages 1A, 1B, all of this stuff which is relevant to us. But this is why it's important when we talk about prognosis. So less than 1, this is the 10 and 20 year survival in Queensland. Just to tell you, you diagnose this disease early and you've got a great chance of being cured. This is T, so in even the worst thickness, greater than 4, it's still 50-50. It's not a death sentence. There are cancers out there that do much worse. It spreads by getting into the lymph channels, and then it can come up as little lumps beside where the primary was, or into the lymph nodes, or it can spread in the bloodstream and it can go to organs. And that's the scary bit. When we see a suspicious lesion, the best treatment is to remove the whole lot. Pathologists love having the whole mole to look at. I'm biased. I'm a surgeon. I use a knife. I have colleagues that will biopsy using shave. The most important thing is that the biopsy was done. We can argue for hours about pros and cons. The most important thing is that it was done. Pathologists love the whole lesion. But a shave and a punch is fine, and particularly important. You saw those things on the heel or that big thing on the lady's cheek. You're not going to excise the whole thing of that. You can't. So then we target the bit we think is the most worrying as a biopsy. What we do then is, once we've made the diagnosis, we definitively remove the site of the melanoma, and then we look at how we're going to manage the lymph nodes. So then we talk about margins, and this is the amount of normal skin. So if it's level 1, the cured one, it's recommended that the patient should have 5 millimetres. This is all about just picking up microscopic cells that we can't see. If it's invaded, so it's level 2 or it's invaded anywhere, then the minimum margin should be 1 centimetre, and that's the national recommendation. And that the evidence, there's no evidence for anything less than that. We think about wider margins when it's a much thicker melanoma, if there's ulceration, or if it's a variant that can grow in nerves. And that's about trying to control things better at the site of the primary. There's no evidence that that margin influences whether somebody is cured or not. It's very worrying. Here we've got a cancer, and the most definitive treatment is chipping a bit of skin out. And that's the best we have. That's the best we have. So, but that's the reality. What about lymph nodes? Because it's on the skin, and that's the next step. Remember, it can spread to lymph nodes, it can spread in the bloodstream as well, it can do both. We can sample the lymph nodes, and some of you may have heard of this term of sentinel lymph node biopsy, and we do, in patients that have higher risk lesions. There's no point in mucking around with people's lymph nodes if the chance of it going there is 2% or 3%. So that's why all of that stratification is important for us as doctors, so that we get a feel for risk and benefit for an individual patient. And you have to trust us with that. But we're using evidence when we make these decisions. So that what we do this sampling biopsy if we think the risk of the lymph node is greater than 10%. And we do the sampling biopsy because it gives us so much more information about the person in front of us. So there's that stratification. So I'm just using this as an example. We use all that information that you don't have to remember. There won't be an exam. But this tells us which are the higher risks. So we get that from the path form. And therefore that gives us the opportunity to discuss things with you. And if we decide that you are in this group and that it's a reasonable thing to do, we then explain to you the process. And what it is we get the radiologist to inject some radioactive dye beside where the melanoma was biopsied. And this is the dye in the lymph channels. This is beside the knee. And then coming up to the groin, and you can see it goes to 3 lymph glands. So these are called the sentinel lymph nodes. So they're the nodes that drain that bit of skin. That doesn't mean they have melanoma in them. That just means they drain that bit of skin. That's all. So we inject in the operating room now a blue dye around the melanoma that gets taken up in the lymph channels. Because the radiologist has made an X over where those glands are. X marks the spot. But in that spot, say in the groin, there's 10 glands. In the armpit, there's 15 to 25. Which one? The X just gives us a guide to making a cut. So what we then do is inject some blue dye, and the gland turns blue. So what we have is the gland will have some radioactivity still in it, because we do it the same day as the radiology, and it will be blue. So there we are, injection around a melanoma, and there's the lymph channel coming into a blue node. So it looks great. And we send that away, and the pathologists look at it, and they tell us whether it has melanoma, and they can actually see with special stains even a small little tiny clump of cells. So that gives us more information about prognosis. So what we get from that is better staging. That is the risk to a person. So if the person has a high risk melanoma, and I look at their thickness, and I look at the thickness and it says they have a 20% chance of recurrence, and then I do a sentinel node biopsy and it's negative, then it's 10% recurrence. And if it's positive, it's 35% recurrence. It's all numbers, because an individual, you're either cured or you're not. But it's all numbers, and it gives people a feel for where they are. So we treat the nodes when it's microscopic. We now have trials where people who are sentinel node positive may be able to participate in trials where we're trying to improve cure rates so we can stratify better. There's no clear evidence that putting somebody through this actually increases their cure rate, though. It gives us information. But we need to discuss the pros and cons with a patient. If somebody presents with a lymph node, the treatment is to remove not just the gland, but all the glands in that region: groin, armpit, neck. The reason is that 20% of patients will have another gland, and it may be microscopic, and you can't predict which gland it is. So we take all the glands. So we need to do a complete removal of all the glands in the armpit, axilla, groin or inguinal area, or in the neck. That's the treatment. What do we do for follow-up? The reason we do follow-up is because we want to identify if there's any recurrence, like in the lymph glands, that we can treat. It's all about talking about early detection. Pip mentioned the risk of a second primary melanoma. In Queensland, it's around 6%, but if you're in the higher risk group, it's probably much higher. And it's also for support and reassurance for patients. However, patients will find their second melanoma or their lump most of the time, 50 to 60% of the time, and it'll be the doctor's visit on the other time, and there's no evidence that the outcome is worse whether the patient found it or whether the doctor found it. So we look at the skin when we follow a patient up, because we know that the risk of not just melanoma but other skin cancers. We also know the people who are at higher risk, family history, multiple moles, and we're looking for other skin cancers head to toe. We examine the site where the primary melanoma was removed. We examine the pathway to the lymph area in transit, and we examine the regional nodes. And we ask, how are you? And if somebody's been perfectly well and now they're not, that's a trigger to investigate why they're not well now. What about tests? I'm afraid there's no evidence that routine scanning, x-rays, blood tests changes what happens to people. If it's in an organ, it's about whether our treatments work. Early diagnosis is imperative on the skin, not so much if it's in an organ. So routine tests don't necessarily change outcome. Chest x-ray would likely be negative. If we do a CAT scan on everyone, 20% will be abnormal, not from melanoma, less than 1%. They'll be abnormal because it's a shadow in the liver and a shadow in the lung, granulomas. I saw a chap the other day who's come yesterday at the melanoma clinic, and he's a plasterer. I said, "Do you wear mask?" "Yeah, sure, doc." And his wife says, "Yeah, he's being facetious." Never. He's got little spots on his lung. I'm sure there'll be granulomas. It'll be what he's been sucking in for the last 30 years. So 20% of the scans will be abnormal when somebody first presents, and that'll trigger a whole series of extra investigations. So if the decision with a patient is to scan, I have to tell them that, because the first thing you tell them when they come back there's a shadow, they think they're pushing up daisies, and it's not necessarily the case. And then if patients present with lymph nodes, we'll always do baseline scans. We want to know where somebody is at that point in time. Regular serial scanning after that time has not been shown to make any difference. So I'm going to now just talk about melanoma that's spread to organs. Anybody got any questions about what I've said so far? I just sort of get the... I'm just wondering whether people are falling asleep yet or not. No.
Can I just ask you one?
Yeah.
I'm still confused with this mole and freckle.
Yeah.
Are they the same or not?
No. So it's a pathological term, and it's also, we use it as a clinical term. So we'll see, like those two young girls that Pip showed, they have multiple freckles. They're not moles. And I had a lot of freckles as a youngster, but they've gone now. So the mole is a much more defined entity. There's a thing called a solar lentigo. Lentigo is a medical term for freckle. And they're bigger, but they're very circumscribed. They look like a big freckle. That's what they look like, a big freckle. Whereas moles look like that. And they have a defined edge. They have a much thicker feel to it. They don't have normal skin as part of the meshwork of the pigment.
Why I asked that question is that 25 years ago I had a change to a freckle.
Yeah.
All the Queensland Cancer Fund ads just said change in a waterfall mole.
Yeah.
I saw my freckle change.
Yeah.
And I ignored it. And then afterwards, when I found out, the Queensland Cancer Fund did a survey, and they then found out at that time 75% of melanomas were coming from freckles. And they then throughout all their stationery, all the sites throughout Queensland were pulled down just because I pointed out to them.
So you're right, and it's all about terminology. But as a pathologist looking at that, it wouldn't have been a freckle. It would have been called a junctional nevus or a compound nevus. But your sense of what it was a freckle. And that's actually much more important than what a pathologist or a surgeon says. So that's why they changed, because what you told them was what the public believed. So we have to change and forget about what our terms and use the terms that the public knows, so that then it becomes relevant to you and the public and not just relevant to the doctors.
Thank you for explaining that.
Yeah. So, yeah.
This one's a brief question. If you have a melanoma on your back, do you still check your lymph nodes for the ones on the back?
Yeah, so I haven't put a picture there. From the waist up, it will drain to the armpits, and that's all over the trunk, and the arms to the armpits, from the waist down to the groins, and the legs, perineum to the groins. And there's a sort of a 5 centimetre thing where it could go both ways. And in the middle of the back, there's a 5 centimetre thing where the middle of the back can go both ways, and 5 centimetres each side could go either side. Yeah? And then head and neck to the neck, and an upper back can go to the lower neck area here, or an upper chest here to the neck area here. Yeah? So what do we do if it's spread to an organ? So these are our options. We can observe the patient, we can remove it. I'm a surgeon, so I have to put that in there, but we can and do safely. We can use chemotherapy. There's these new proliferation inhibitors. I'll explain what that means. And we can use immune therapies. So the decisions are based upon the extent of the disease, where it's spread to, how many organs. The decision is made upon the condition of the patient. Is the patient well, fit? Is the patient up for what we could do to them? We then are weighing up the risk and the benefit to the individual patient. And that may be putting into this decision-making process the risk of an operation versus starting some chemotherapy that may not work versus starting even new treatments or even trials. So now we're in an environment where we actually have some treatments that might work for at last. And so we are in an environment where we're always discussing a number of options, whereas only 5 years ago it was, if you can't cut it out, we'll just give chemo and it's probably not going to work. So times have changed. You're a part of a paradigm shift. We also have to consider at times that these treatments may actually harm the person in front of us. And it's very important for us to know when we shouldn't be doing something that will not help, but will hurt. And therefore, the time when we need for the patient to have symptomatic care and supportive care. And that's a very important component of dealing with some patients who present with the disease when it's spread to organs. And it's very important that the patient is informed and aware and has realistic expectations along their journey. So the role of surgery, it's in selected patients where we feel we can get it all out. There's no point in taking a piece out and leaving it still there. That hasn't helped anyone. Usually it's local disease, 1 or 2 deposits in a single organ, and where the risk of the surgery does not outweigh the benefit. It's not reasonable if it's spread to multiple sites. People often say, because what you believe, which is true, if it's cut out, it's gone. But when it's reached to the stage 4, the risk that it's microscopic in other places is extraordinarily high. And what we see is the tip of the iceberg. So directing our treatment just to the tip of the iceberg may be the wrong thing to do. It is better to treat the whole iceberg, to treat the whole person rather than the thing you're looking at. So it's not reasonable if it's in multiple sites. And also, it may be in multiple sites, but there's 1 or 2 that's very painful. symptomatic, that we can deal with surgically, because it is removed, that will help the person, help their palliation. So surgery is still an important part of palliation as well. So the old-fashioned drugs, dacarbazine, when I first started as a doctor, when I first was a registrar and started in the melanoma unit, this was the only drug. That's it. And that is still the standard chemotherapy for 40 years. That's how far we've come until the last 2 years. Temozolomide, great advance. It's just the same drug, but it's the oral form. Not available in Australia because it costs too much. And you can have this drug in Australia at about a third the price. And fotomustine is a new drug that has the same potential benefit as dacarbazine, but is used as a second line. And the advantage is it crosses the blood-brain barrier and can be used where people may have cerebral disease, whereas this drug does not cross the blood-brain barrier. So there are pros and cons for the use of these drugs. The newer therapies are more relevant. If you look at those therapies, the chance of somebody getting a response means reduction in disease, is about 1 in 5, 1 in 6. And about a similar number will stabilise. The disease will stop growing for a period of time. So that's the figures. So that's why there's been this huge focus on new therapies. And the new therapies are all about trying to target the host, that's the patient, or target the tumour. So an immunotherapy in melanoma seems to make sense because we know that some people, the melanoma will regress and go away. We have some people that will present with a lymph node but no primary on their skin. Where did that go? Well, it probably regressed. We know that people have presented with lung secondaries but there's nothing to find anywhere on the skin or anywhere. Well, it probably regressed. We know that some people, the disease just disappears even though it's spread. So it must have been that individual's immune system that did it. So this renal cell cancer and some other cancers seem to be much more immunologically relevant than other cancers. So there's been a large focus in this area in melanoma. So if we look at some of these therapies that target the patient, and what it's about, these were the older fashioned ones, and they stimulate the immune system generally. So the immune system is ramped up to say, hey, it's like somebody on Red Bull, and they're running around, or the red cordial in my kids, and they're, what is this, something I'm going to do, something I'm going to do, something I'm going to do. So it actually changes the whole immune system, and drugs like interleukin were used, but that actually killed some patients too. Very toxic. Never really used in Australia. Interferons were used. It may have slowed the disease down, but didn't completely eradicate it when a disease had spread. But the focus was with these diseases, so these are all parts of everything I'm talking about now is all part of a jigsaw. These are all about these things here. These are our warriors. These are the soldiers in our blood that are fighting the fight. This is a T lymphocyte. The T lymphocyte is the thing, it's cytotoxic, which means it kills cells. This is the thing that's out there fighting the fight. This is the army. So the whole focus is being, what can we do to make these things work better, make them into a better army, rather than a single few cells, but a whole army of cells, battalions of them. And so a new drug that stimulates the immune system, Yervoy, so that you know about this, you've seen this, it's now available, but not on the PBS. So it enhances the T cells to kill cancer. So it actually targets the T cells more specifically than those other things that were used in the past. So it's a non-specific change to your immune system. So it has some side effects that are quite significant and can be toxic in that it can create immune side effects on somebody's normal system. So I'm going to show you a couple of cartoons that they're showing in, and you think, oh God, here we go. But what this thing here, this is the trigger. Just see this as the trigger. Now here it is. This is a cell that's got bad proteins. This is presenting the bad proteins, the cancer proteins, to our T cell. This is the T cell. This is our army. This is a single soldier that's going to become an army. So the bad proteins, we have these cells, antigen-presenting cells, dendritic cells in our body. They've seen the cancer, they've taken a little sample, now they're showing it to the T cell. They're saying, now if you see this sample, you get it. And that's what it's doing right here. Over this area here, that's showing the T cell what it's got to look for when it goes to kill the cancer. But the cancer will switch this thing off. This thing here can't be switched off. This has got to keep going. What will happen is that sometimes this is switched off and the T cells just don't get the message. They don't get it. Yervoy, ipilimumab, blocks this area. It blocks the switch. It makes the switch stay on. In fact, it promotes the switch so the T cells are hyperactivated. So the T cells work better than they did before. So that's how it works. Very non-specific. And so it's out there looking for badness. And hey, cancer is a badness. It's got to recognise that. So that you see x-rays like this, where this is a melanoma secondary, and people have had great responses. A large percentage of those people, it comes back again. But there have been some people that have had Yervoy that have gone for years now and have been well. So it's an advance. There's a new drug. So this is Yervoy. This is that dendritic cell presenting the bad proteins to the T cell. Here we've got the switch. The switch is still off so that the T cell's working. So that's between our cell presenting bad proteins to the T cell. Now what the T cell's got to do is it's got to kill the cancer. That soldier and that battalion have got to kill the cancer. So now that happens over this side. So now we've got the T cell here and he's got to kill the cancer because what he's got is he's recognising this bad protein. There it is. Now that's the thing I've got to target. I'm not targeting normal tissue. I'm targeting this thing here. But cancers are unbelievably remarkable things. They create a shield. Flash Gordon stuff. There's this shield around it that will not let our immune system recognise it as bad. So there is a new compound, so there's new trials coming out, they're only just starting, where these compounds break down the shield. They block the shield so that the T cell can work. Because the cancer cell has this area here, will block on the T cell and will stop the T cell from working. That's how its shield works. But if you can block that, the T cell, which is hyperactivated, recognises the bad cell and will kill the cell. That's the principle. This is the next line of drugs that are just about to start trials for patients with metastatic disease. And it may well be, unfortunately, we're stuck, because these are toxic substances, with trying one at a time. You can't put them all together. We could harm people. And it may be the future will be the combinations of these things. As you can see, it seems to be a natural progression. Then we can target the tumour. So I'm getting close to finishing. So just as an interesting thing, somebody found that if you inject some cancers, recurrent breast cancer, melanoma, with a dye, the dye's been out there for years, used to assess liver function, look at eyes, and you can inject it with this dye, it will actually kill some cancers but won't kill normal tissue. So we have this patients who present with little spots of melanoma in the lymphatic drainage, very difficult to treat, and we have all sorts of different treatments that we try. But this is an interesting thing, and it's just to show you, and there's a couple of people in the audience that have had my needles shoved into them treating this thing. Looking over there. So this is melanoma. It's in the lymph channels. We call it in-transit disease. Too much disease to cut off. It's not spread everywhere. Chemo is very toxic. Doesn't work that well. What else can we do? So we treated this patient by injecting it. It's got this really pretty magenta colour. Then this is killing the melanoma. And then 12 months later. So it doesn't work for everyone, but 20% of people get a complete response, and 20%, half the disease disappears, and in a lot of those people, they're still disease-free. So these things are happening. This is all new and happening in the last few years. And then we have these cells. These are our normal cells, the nice pretty pictures. The dendritic cell is a cell that actually is the antigen presenting cell. So it finds the cancer, abnormal proteins. I've got to find a T cell, got to show it this abnormal protein. So it's our presenting cell. So there have been a lot of trials, and we've done them too, where we've concentrated an individual person's own dendritic cells. And we've taken melanoma tissue, their own melanoma tissue, and put it together to make the dendritic cell recognise that tissue. And then made a vaccine and given it back to patients. And there have been a lot of studies in the world. We've done our own, and we had very selected patients, very small volume disease, their immune system still functioning, and had some people where they had really good response with their own vaccine. This is melanoma here, and there's nothing there, melanoma there and there. So melanoma here, nothing there, melanoma here and there. Great, incredibly expensive, creating a single vaccine for one person, but when you try to get it out there for large populations of people, it's a start, it's part of the jigsaw. We then tried that vaccine in patients with using their lymph nodes secondary, hoping that if we gave it to them before they had the disease that had spread, it actually might work. But unfortunately, it didn't make any difference. So we've had to move on. So, but the information we got from those studies and trials on manipulating immune system are all part of the jigsaw, I mentioned MAGE. We've just finished a trial. Patients who are lymph node positive, who contain this protein, because this protein does not exist in normal cells, and it exists in 50 to 60% of patients with melanoma. So, and what we've done is we've trialled patients with lymph nodes who are positive with the MAGE vaccine and a placebo, and the results of that study will come out in about February, March next year, we think. 1,300 patients in the world, and about 100 and something patients came from Australia, with two major centres in Australia, Sydney and us, the major investigators internationally. So that's on the way. Fingers crossed about that. And then here's another big complicated cartoon. So now what I want you to think about is that this yellow line at the top, so that's the cell membrane. What's underneath that is engine room. Just think about engine room. So this is the engine room that is making the cell work. This is a cancer cell. And this is the engine room that is making the cell grow, proliferate, create the shield. And in the last 10 to 20 years, we've started to define the pieces of the engine, which we didn't know before. And the pieces of the engine are all these words and acronyms that you see here. So the ones to focus on is RAF and MEC. So RAF and MEC in this line here. That the blue lot coming down here. This is a proliferation pathway. This is what makes the cells grow. So if you have a melanoma deposit that contains these genes, if we find a way to block that gene, we stop the cell growing. This is the BRAF inhibitor. So that's where it's working. So this is the future. Everything you see here, you don't need to remember any of that. Remember, no exams. You don't have to remember anything. But that's the engine. So the future is targeting. It's all about targeting therapy. Targeting these pathways to stop the cells growing. So the new trials are trials looking at BRAF, MEC, the combination of BRAF and the MEC inhibitors, all sorts of funny big names. And these are working in people with stage 4 disease, with metastatic disease. The future then is to find who are the people at risk then who don't have stage 4? The ones with lymph nodes. So the next set of studies, all starting in a matter of months, will be using these drugs in patients who are lymph node positive. Hoping that, because their immune system is still probably better than the person with stage 4 disease, and it will work better. So the future is targeting all those areas. So this is what you see with nice pictures, liver secondaries, bowel secondary, bone secondary here, and across the line you'll see liver, bowel, bone. Across the line you'll see diminution of the disease. These are stopping the growth. They're tablets. You stop the tablet, it regrows. It's not the answer. We need to kill it too. That's the future. Yeah.
Mark, if you could just go back to the previous slide for a second, the complicated one. As I understand it, on that graph, and I'm BRAF positive and I've been on the drug and I'm in my 4th year. Okay? So if you go to BRAF, which is the little blue, white, the blue one there, that one there, if my tumours regrow, then they will regenerate and they will change DNA, inverted commas, to MEC. Is that correct?
No,
Well,
not necessarily.
How do you actually describe it?
So this is all. What happens is that this is still part of the proliferation pathway. It's not about RAF going to MEC. These are still part. They're all part of the way the pathway down. So if you attack RAF and MEC together, you actually get better outcomes, and that's what the trial has shown. But it's not RAF going to MEC. It's points of attack.
Okay, so in terms of how does it, what's the arrow mean then from RAF to MEC? If you're attacking it down
We're talking about genes, and these are genes that are all important components for cells to work. And these genes are all very similar and on similar areas. So, and this is all, and we believe that this is one pathway that's important with these combination of genes for cell growth and proliferation. So it's about attacking one gene isn't going to be the answer. It is for some people, but not for the majority. So you've got to attack it at a number of different sites, and that's the plan. And then there are other proliferation pathways, because only 50% of patients are positive. If you're under the age of 40, it's 80%. So there are other proliferation pathways, not just that. And that's where other attacks will need to occur. And there'll be some people who have both. So the future, the future will be combinations of all these things. And these are points. I guess the arrows are confusing for you, but these are points where we want to attack things, and if we can, in multiple ways. Because what we need to be able to do is not just stop the cell from growing, but get rid of the cell as well. Yeah. So the summary is we now have, in the last 5 years, new therapies for stage 4 disease that we didn't have. It's not the complete answer. They're pieces of this puzzle. The future is likely to be combinations of these therapies, and especially for stage 4 disease, and the future will be testing these new therapies in stage 3 disease, lymph node disease, before people get to stage 4. Because stage 4 is another probably level of immune compromise in an individual patient. This is just I want to finish, because I will always highlight the absolute need for us to prevent and to diagnose early. We want to try not to have people who have to be on BRAF. We want to try to minimise that. If you look at that map of the world, and if you look at the countries between the Tropic of Capricorn and the Tropic of Cancer, and if you look at and think about the natives to those countries, if you're native to that country, every one of them will have pigment protection, every one. The non-natives, so that's Tropic of Capricorn, we weren't built to live in this environment. Pip said that, so I just want to repeat it. We weren't built to live in this environment. And so everything I've said, what is still really important was said by Neville Davis, my mentor, that the solution to melanoma lies in public and professional education, which should be encouraged throughout the world. And he said that in 1973, and that hasn't changed. Thanks very much.
Thank you very much.
Okay.
Are there any more questions for Mark?
Yeah.
Like you mentioned the chemotherapy, you mentioned radiation.
Yeah.
And I had
Well, I'm sorry I didn't mention it, and my very good friend and colleague Brian Burmeister, who's the director of the Radiation Oncology Unit at PA, would have pulled me aside for that. I should have mentioned it because it's really very important in a number of areas. In patients who have lymph node surgery, there are a group of people that are at very high risk that no matter how good the surgeon is, it'll come back again. And in a small percentage of people, it comes back in a disastrous way that is very, very difficult, almost impossible to treat. And Brian was the lead author in a large Australia-wide study that's been published internationally and is seen as the most important radiation trial in the world, where patients with high-risk melanoma to lymph nodes, neck, groin or axilla some didn't have radiation and the other half did, and it showed a much higher, a better control rate using radiation. So in selected patients, we advocate radiation on a just-in-case basis. Then radiation also becomes really important for certain special types of primary where there's a high risk of local recurrence, and it becomes very important for people where it's spread and we can't treat it surgically, or treating it surgically carries huge risks that are not right for the patient, where radiation can be life-saving. So radiation, it's commonly said radiation doesn't work in melanoma, and that's not true. There are a lot of things that don't work in melanoma, and to single radiation out is wrong. Radiation can be a godsend for us. And the combination of radiation with surgery then radiation, and the addition of chemotherapy is commonly used, and the radiation oncologist is an absolute integral part of the combined team in our unit. We run a clinic with surgeons, medical oncologists and radiation oncologists. Right.
The PA hospital, Sandro Presidio.
Yep.
And I'm on my second year now, so I'm hoping that it's all gone by the time my fifth year comes up. But I had radiation for 6-8 weeks.
That's right.
Plus chemo.
That's the adjuvant protocol. That's right. It's tough. It's tough, particularly in all areas. And we're fair-skinned people, and fair-skinned people get melanoma, and fair-skinned people burn with radiation, and there's a whole bunch. Other thing I didn't talk about is the nodal surgery. Being a surgeon, I avoided complications, right? So lymphedema is a common complication and can be a really difficult thing for patients to have to deal with. Unfortunately, the alternative is much worse. So people live with lymphedema and they tolerate lymphedema, but we're doing a lot of things to try to deal with that now too. Yeah.
Well, Mark? Oh, sorry.
A few years ago I had breast cancer and I had quite a number of lymph nodes taken out under my arm.
Sure.
Am I more at risk now as far as my lymph
No.
system goes?
No, you're not. Absolutely not. So that's the other thing I guess I haven't stressed. All cancers are really different, and the drugs we use are so different to all the other cancers. The other thing Pip didn't say is the death rate from breast cancer in the last 20 years is less now, and colorectal cancer is less now, but melanoma is flat. So we don't say what's happened is these other things, adjuvant chemotherapy, adjuvant treatments, chemos that work better. Breast cancer has a number of other Herceptin and other drugs that work when it's in stage 4 disease. We're now getting drugs that do that. So the reason you had the lymph nodes taken was because it was to test to see if they were positive. And if they were positive, then you get chemotherapy because you have a 15% improvement in your survival rate if you have chemotherapy for positive lymph nodes. So
Good reports from me, so.
yeah. So, and then the only thing that you might be at risk of is swelling in the arm, and you just got to be careful of cuts and all of those things. Right. But having those lymph nodes out does not affect the rest of your body. You have hundreds everywhere. It just impacts on the drainage pattern from that one area.
Thank you very much.
Okay.
Well, thank you very much.
Okay.
I assisted as well.